Hello and welcome to my presentation on pheochromocytoma. Our chief complaint. We have a Caucasian female patient, age 40, who presents with episodes of severe headaches, palpitations, sweating, and high blood pressure. These symptoms have been intermittent over the past few months, but have recently increased in frequency and severity. She reports episodes of feeling extremely anxious, flushed, and dizzy, often without an obvious trigger. Some more information about our patient. She has a past medical history of hypertension diagnosed 3 years ago. Previously managed with lifestyle modifications and a low-dose beta blocker, the hypertension has become increasingly resistant to treatment. She has a history of intermittent migraines for several years, controlled with over-the-counter analgesics and occasional prescription migraine medication. She has mild managed anxiety and reports that her current anxiety episodes feel different from her past experiences. She has allergies to penicillin, which produced a rash, but no anaphylaxis. She has no food allergies or environmental allergies. She works as an administrator and reports moderate stress levels at work. She's a lifelong non-smoker and consumes alcohol on occasion with 1 to 2 glasses reported per month. She drinks caffeine, 1 to 2 cups of coffee daily. She participates in light to moderate exercise 3 to 5 times per week, primarily walking and yoga. She has no history of recreational drug use. Her surgical history includes appendectomy at age 22 with an uncomplicated recovery. She had her second child by cesarean section 12 years ago without postoperative issues. Her family history includes her father with a history of hypertension and type 2 diabetes. Her mother, deceased at age 65 from myocardial infarction, also had a history of hypertension. She has one sibling, a brother, living age 45 with no known health issues. There is no known family history of pheochromocytoma or other adrenal gland disorders, but there is a noted prevalence of cardiovascular conditions. Her current medications are metoprolol succinate 50 milligrams for hypertension management, taken once daily. She takes sumatriptan 100 milligrams as needed for migraines. Over-the-counter supplements include a multivitamin daily and a vitamin D supplement recommended by her primary care provider due to low vitamin D levels. She takes magnesium 400 milligrams daily in the evening to help with migraine prevention and relaxation. Differential diagnoses. Pheochromocytoma is rare and prevents like several other diseases and is often overlooked. One of these is essential hypertension with symptoms of headaches, dizziness, palpitations, anxiety, blurred vision, and fatigue. Panic disorder can also present with palpitations, sweating, chest pain, nausea, shortness of breath, and dizziness. Hyperthyroidism presents with tachycardia, hypertension, sweating, tremors, anxiety, and fatigue. And carcinoid syndrome has symptoms of blood pressure fluctuation, flushing, tachycardia, anxiety, wheezing, and dizziness. In pheochromocytoma, there are episodic surges in blood pressure, which sets it apart from the other diseases. Palpitations, sweating, headaches, anxiety, nausea, and vomiting are also symptoms of pheochromocytoma. Pheochromocytoma, PCC, overview, is a rare neuroendocrine tumor originating from chromaffin cells in the adrenal medulla. It is caused by excess catecholamine secretion, primarily norepinephrine and epinephrine. It occurs in less than 0.2% of patients with hypertension. It causes an increased sympathetic response, leading to hypertension, tachycardia, and hyperglycemia. Other signs and symptoms include headaches, diaphoresis, anxiety or panic, and pallor or flushing. It can be potentially life-threatening due to hypertensive crisis if untreated, so diagnosis is very important. In this case, the chief complaint of episodic symptoms, particularly with hypertension, palpitations, sweating, and headaches, points to pheochromocytoma as a likely diagnosis. Further testing, such as plasma or urine catecholamines and imaging studies, is typically indicated to confirm the diagnosis and localize the tumor. We will explore some of these diagnostic tests later in the presentation. First, let's learn more about the pathophysiology and clinical manifestations of the disease process across the lifespan. Pheochromocytomas arise from chromaffin cells that form the tissue of the adrenal medulla, the inner part of the adrenal glands located on top of the kidneys. A part of the sympathetic nervous system, chromaffin cells synthesize, store, and release catecholamines, primarily norepinephrine and epinephrine. It also monitors oxygen and carbon dioxide levels and helps regulate blood pressure and respirations. Abnormal proliferation of chromaffin cells form a tumor that produces and releases excessive amounts of catecholamines. The uncontrolled chromaffin cell growth can be triggered by genetic mutations, alterations in proto-oncogenes, and growth factor dysregulation. The tumors can be familial or originate sporadically. Norepinephrine and epinephrine act as alpha and beta adrenergic receptors, causing widespread sympathetic activation, triggering the fight or flight response in the absence of an actual trigger. Alpha-1 receptors, found in vascular smooth muscles, cause vasoconstriction, leading to hypertension. Rhinodine-2 receptors control the release of calcium to the cytoplasm from the sarcoplasmic reticulum and trigger and regulate muscle contraction. Beta-1 receptors cause stimulation and initiate a cascade of activity in the cells of the SA and AV nodes, resulting in increased heart rate and contractility. Beta-2 receptors cause vasodilation in skeletal muscles and bronchodilation, causing peripheral effects like tremors and sweating. Catecholamine overproduction leads to episodic sympathetic spikes with hypertension, palpitation, and anxiety. In chronic cases, catecholamines can alter vascular tone, leading to persistent hypertension. Unlike normal adrenal medullary cells, chromaffin cells in pheochromocytoma tumors are not subject to usual feedback mechanisms. This leads to unregulated episodic secretion of catecholamines, resulting in a sudden fight or flight response, even in the absence of stressors. The effects on glucose metabolism, hyperglycemia. Catecholamines increase glucose production by stimulating glycogenolysis and glucogenesis, while decreasing glucose uptake in tissues. This effect is the part of the fight or flight response, but can lead to episodic hyperglycemia. Cardiac and vascular complications from chronic catecholamine exposure cause damage to blood vessels and can lead to cardiomyopathy, arrhythmias, and myocardial ischemia from prolonged hypertension, and increase the risk of aneurysm or stroke. Associated genetic mutations. Approximately 30 to 40% of pheochromocytomas are linked to genetic mutations and syndromes. Multiple endocrine neoplasia type 2, von Hippel-Lindau syndrome, neurofibromastosis type 1, and succinate dehydrogenase mutations. These mutations may result in altered cellular metabolism, increased oxidative stress, and unchecked cell growth, contributing to the tumor formation and unregulated catecholamine production. In summary, episodic and sustained hypertension due to alpha adrenergic effects, tachycardia and palpitations as a result of beta adrenergic effects on cardiac tissue, sweating and anxiety caused by general sympathetic activation, and metabolic effects like hyperglycemia due to increased glucose production and lipolysis are all consequences of pheochromocytoma. Across the lifespan, there are different clinical manifestations. In infants and young children, PCC is rare, but it can present in association with genetic syndromes. Symptoms such as sustained hypertension, behavioral changes, paleness or flushing, failure to thrive, and seizures can be seen. Again, this is a rare presentation in infants and young children, but if detected incidentally or due to symptoms like irritability or lethargy, unexplained crying or irritability, poor feeding and sweating, episodic pallor or redness due to catecholamine surges, and chronic hypertension or metabolic stress that may impact growth and weight gain. These are all signs of PCC in infants and young children. In adolescents, There's an increased prevalence in children with familial syndromes like MEN2, VHL, or NF1 that may develop pheochromocytoma. Symptoms in adolescents are often episodic but can be sustained. Adolescents may report headaches, dizziness, or blurred vision due to hypertension. They may present the classic triad of headaches, palpitations, and sweating, paroxysmal or persistent. Anxiety-like symptoms may present with anxiety, panic attacks, or behavioral changes due to excess catecholamines. Growth and development can be affected with delayed puberty or stunted growth from chronic illness that may lead to growth milestones. Secondary symptoms, recurrent headaches, weight loss, and decreased energy levels may also occur. Peak incidence in age 30 to 50 years. Symptoms include paroxysmal hypertension, blood pressure spikes with episodes of severe headaches, sweating, and palpitations. Persistent hypertension, around 50% of the cases presented have this sustained hypertension, especially if undiagnosed. The classic triad symptoms may present and commonly include headaches, palpitations, and diaphoresis. Hyperglycemia can be present as glucose intolerance or incidental hyperglycemia. Other symptoms include weight loss due to elevated metabolic rate and potential anorexia, orthostatic hypotension, episodic catecholamine surges followed by lows that can cause blood pressure drops, neuropsychiatric symptoms like anxiety, panic attacks, or mood swings, and familial syndromes. Patients with inherited mutations often present earlier or have bilateral tumors. In older adults, older than 60 years of age, there's a lower incidence. PCC is less common, but the disease can be severe if undiagnosed or untreated. There's also an atypical presentation in this age group with symptoms that may be mistaken for other cardiovascular or metabolic conditions common in older adults. These include hypertension complications, fatigue and weight loss, orthostatic hypotension, and blunted classic symptoms. The classic triad may be less evident, with symptoms more often related to complications like atrial fibrillation, heart failure, or angina. And often, symptoms may be less specific and may be attributed to aging. There's also an impact on comorbidities in this age group. Catecholamine excess can exacerbate pre-existing cardiac conditions, and diabetes can be aggravated by the glucose control in diabetic patients due to catecholamine-induced hyperglycemia. Laboratory and diagnostic evaluations include biochemical testing, which is the primary diagnostic tool. Labs including plasma-free metanephrines and 24-hour urine fractioned metanephrines and catecholamines. Imaging studies to localize the tumor include CT, MRI of the abdomen, MIBG scintigraphy if extra-adrenal or metastatic disease is suspected, and genetic testing for hereditary syndrome if indicated. It's important to have additional testing for differential diagnoses like clonidine suppression test, thyroid function test, and serum cortisol. In this case finding, the lab results were elevated plasma metanephrines and catecholamines. The adrenal protocol CT scan with contrast demonstrated a well-delimited solid mass with marked enhancement. Genetic results were negative for a mutation in genes associated with familial pheochromocytoma. Management and treatment. Adrenalectomy surgery to resect the tumor is the only curative treatment. It is the standard of care for patients who are surgical candidates. Minimally invasive surgery is favored over open procedures that were once the standard of care. Perioperative management. An alpha blockade such as phenobenzimine is prescribed for 7 to 14 days prior to surgery to control blood pressure and prevent hypertensive crisis. Managing hemodynamic instability is the main intraoperative concern. Close monitoring and control of blood pressure are imperative for continued stabilization postoperatively. Targeted therapy options in patients with malignant and metastatic disease, which account for 10 to 20% of patients, are being explored in clinical trials and are directed at checkpoint inhibitors to help control cell growth rate. Ablation and palliative care, including radiofrequency ablation, cryoablation, and embolization to suppress tumor growth, are also available treatments. The cultural and sociocultural considerations, prognosis and expected health outcomes include health literacy and awareness. Understanding symptoms and cultural perceptions of symptoms like palpitations or anxiety may lead to delayed presentation in some communities, as symptoms are sometimes stigmatized or attributed to non-medical causes like nerves or stress. Education and awareness is so important in some populations because of lack of awareness of rare conditions like PCC that can lead to delays in seeking specialized care or obtaining an accurate diagnosis. Access to health care and socioeconomic barriers. Cost of diagnostic tests and specialist consultations can be prohibited for underinsured or uninsured patients. Access to specialists in rural or underserved areas may have limited access to endocrinologists or facilities equipped to perform the specific laboratory or imaging studies. Cultural beliefs about surgery and medications. Some cultures have specific beliefs about surgery that may affect acceptance, particularly when surgical removal of the adrenal gland is suggested. Perceptions of medications. Alpha blockers and beta blockers are essential in preoperative care, but patients with cultural concerns about Western medicine may need more education and support to understand the importance of the medications. Genetic testing and counseling. Familial syndrome. Genetic counseling may be required for those with inherited forms of pheochromocytoma. Some cultures may be resistant to genetic testing due to privacy concerns or beliefs regarding hereditary diseases. Family-centered decision-making is important in some cultures, and understanding this can improve adherence to treatment plans and follow-up. Prognosis. Early detection and treatment. Favorable outcomes with early diagnosis. When diagnosed early and managed surgically, prognosis is generally good, with a 5-year survival rate exceeding 90% for benign cases. About 10% of cases of pheochromocytoma are malignant, with a worse prognosis. In these cases, survival rates vary widely depending on the extent of metastasis. The impacts of delayed diagnosis can result in long-term cardiovascular damage, increasing the risk of complications like myocardial infarction, heart failure, or stroke. Recurrence rates are approximately 10 to 15%, emphasizing the importance of long-term follow-up. Familial syndromes. Increased risk of recurrence in patients with genetic forms of PCC may have bilateral tumors or develop additional tumors over time. Monitoring for other tumors and genetic syndromes like MEN2 and VHL increase the risk of other tumors as seen in medullary thyroid carcinoma and renal cell carcinoma and require ongoing surveillance. Postoperative recovery. Most patients experience normalization of blood pressure post-surgery. However, some may require continued antihypertensive therapy. Symptoms like headache, sweating, and palpitations generally resolve after successful tumor removal. Long-term management. Lifelong monitoring of plasma, metanephrines, and blood pressure is crucial to early detection and recurrence, especially in those with hereditary PCC. Managing and maintaining control of comorbid conditions like cardiovascular disease or glucose intolerance is important for quality of life. After treatment, patients generally return to normal lifestyle, but some may need psychological support for stress or anxiety resulting from chronic symptoms before diagnosis. Genetic counseling and family education are beneficial in hereditary cases to help family members recognize symptoms early. As with management of any disease or condition, PCC patients can increase their life expectancy and quality of life with a healthy diet, regular exercise, and continued follow-up with healthcare professionals. Thank you for listening to my presentation. And here are my references.